Hi, welcome everyone. So obviously you're watching from Instagram. We're simulcasting multiple platforms. So my name is James Marin. I'm an integrative registered dietitian, environmental nutritionist, co-founder of Married to Health.
I'm Delia Marin, registered dietitian nutritionist, and also one of the co-founders of Married to Health. We are an integrative nutrition practice, and we have 5 dietitians total. Three of us specialize in the gut. We also have other dietitians who specialize in things like neurodegenerative disease, metabolic disease, weight loss, intuitive eating, family nutrition. So we got your back when it comes to what you and your family need to do to tolerate more plants.
And if you guys are watching today, we are going to be discussing the IBS IBD connection. For those of you that aren't aware, these are 2 conditions. And we're going to break this up into 2 parts because it's quite a hefty topic. So if you guys don't know, we go live twice a month. So every other week, we're going live on a different topic related to gut health. And of course, we specialize more so in IBS and SIBO, but we love all things gut. We really feel gut health is the nexus of all health. So we say that a lot. We also believe in our little tagline, which is heal with each meal, right? Because we know through research, eating and being healthy and the meals you eat will shape your gut microbiota. So it is important to heal with each meal, and you can heal with each meal, most definitely, because you are shaping your gut microbiota. So,
and with that, I totally believe that, food can be very, very preventive. Food can be very healing, but I like to tell my patients, your gut symptoms that you have today aren't just a reflection of what you ate today and yesterday. Right. And very much with IBS, IBD, we'll explain what both of those are. That can be true. So when I see patients with both IBS, Irritable Bowel Syndrome, IBD, Inflammatory Bowel Disease, they come to me and they're like, I ate flax seeds. And that's what did me in. I had a huge flare because of those flax seeds. Well, there's a lot more that goes into it. And we want to talk about common causes, especially we want to mention IBD because we've been talking so much about IBS. If you've missed any of our past videos, you can always go back and you can always watch more information and learn more information about IBS, SIBO especially. That's kind of our special sauce. We absolutely love SIBO. And so we speak a lot on SIBO, but we wanted to make the connection today between IBS and SIBO, small intestinal bacterial overgrowth, or intestinal methanogenic overgrowth. It is a type of IBS. And like I said, sometimes the symptoms overlap one another. So sometimes patients end up getting diagnosed with IBD, and maybe they were diagnosed with IBS first, and for years they thought, I have IBS, right? I have the similar symptoms. And certainly with both, one might be experiencing bloating and gas. Both have a very likely component of dysbiosis. Not always with IBS, but for many people with IBS, Irritable Bowel Syndrome, they do have some form of dysbiosis, aka imbalance of inflammatory microbes to those that help reduce or are anti-inflammatory microbes. This definitely is usually present in those with IBD as well. And so there can be overlap, that gas, that bloating, the discomfort, change in bowel habits, whether it's frequent stool or constipation. So again, sometimes there isn't necessarily that due diligence that's done, or maybe the symptoms haven't presented themselves 100% for one to be able to say, okay, this seems like IBD. So really working with your care team. And that might consist of, we've spoken before, a good gut care team can consist of your primary provider, a gastroenterologist, a dietitian, maybe a therapist, maybe you have pelvic floor therapy involved. So working with your care team, really communicating your symptoms and updating your symptoms every single time will give your care team the best idea of what might possibly be going on. So I'd love to speak a little bit to really the common causes or the common reasons. And I think for some people it might be idiopathic, meaning we might not always know why you got IBD or why you have symptoms of IBS, which is a disease of, the gut. And IBS can oftentimes be furthered by things like dysmotility, lack of motility. It can be also presenting itself due to visceral hypersensitivity or overstimulation, oversensitivity of some of your nerves in your gut. We know that dysbiosis can play into IBS, other diseases one might have, like diabetes and other neurodegenerative diseases. So there are so many reasons behind IBS. And one with IBS, again, IBS is a diagnosis that's based off of symptoms that someone might feel. But when someone has irritable bowel syndrome, they might have, again, that gas, that bloating, that stomach discomfort, that cramping, nausea, fatigue, change in bowel habits, whether that's constipation, diarrhea. So let's talk a little bit more about IBD, inflammatory bowel disease. And again, just like I said, we don't always know what causes IBS. I think we can really say the same about IBD. So again, inflammatory bowel disease.
Right. But we do know there are factors, right? So we do know there are factors that play into creating this inflammation, right? Creating this inflammatory response that's really just overexerted and overexpressed in the body and then causing damage. So that is IBD, right? In this case, it's causing damage in your colon, right? And two common diseases under that IBD umbrella are Crohn's, which are autoimmune, which would be Crohn's, right? And so it's important to understand that with these diseases, you are having an inflammatory response, you are creating damage in the colon, and that is causing a host of symptoms, right? So that could include blood in the stool, that can include fever, it can include, of course, bloating and diarrhea, mucousy diarrhea, or
mucousy formed stool. It's not always diarrhea necessarily, but certainly it can be looser stool.
And what's interesting, along with these symptoms, you can also get nutrient deficiencies, which then cause a host of other symptoms themselves. So it becomes quite this like intertwined ball of yarn, and you're just like trying to unravel it, and it just becomes more and more complex if you do not take care of it, and if you are just kind of letting it go. This is definitely, when it comes to IBD, you do not want to just let it go, right? You're not just going to be like, oh yeah, that's normal for me to have some blood here and there in my stool, no big deal. It's like, it's a big deal. You do not want that. So
blood is usually a reason to really go see a specialist and really try to figure it out. And we've been taught that if you're having such urgent stool that it's waking you up at night and you're not even able to sleep through the night, that might be an indicator that you have so much inflammation in your colon or in your small intestine, anywhere in your intestines, that it's waking you up. That might be an indicator to go get things checked out. And first, your care team might run some blood work. They might run a few stool tests to try to decipher, okay, is it IBD? They might check your fecal calprotectin, your fecal lactoferrin, and a couple of other things via blood. And then if they feel like it's necessary, maybe some of that fecal inflammation came back elevated, they might then go ahead and recommend a colonoscopy, because that really is a great way for them to get two really important pieces of data. They'll get kind of a visual because a camera is inserted into your rectum. They get to look at the entirety of your colon. So visually, the gastroenterologist, who's a trained specialist in this, will get to kind of visualize and see, okay, does it look like you have any fissures? Does it look like you have a thickening of the muscle inside of your gut? Is that present in just the colon, or when they did an endoscopy, was that present in your small intestine? So they'll see visually what's going on. Is there ulceration, or are there, it almost looks like cuts or scabs within the mucus layer and within your epithelial lining.
I totally forgot. Yeah, ulcerative colitis. I said Crohn's. I don't think I said ulcerative colitis earlier. Those are the two diseases under IBD. But sorry.
Yes. So they not only look, but then they take samples. So they'll biopsy samples, and then a pathologist will look under a microscope, because sometimes it's not visible to the naked eye. You might have microscopic colitis. So you always want to ask. I just had this happen with a patient this week. He did his due diligence and he went and did an endoscopy colonoscopy, and he was told everything looks normal. So I asked him, do you have pictures of your procedure? And then what did pathology say? Did you go back for your follow-up afterwards? Because oftentimes they'll give you right away pictures, and the doctor will give you their first impression of what they see. He said, I didn't go back for my follow-up. So we don't know what the pathologist said. He was never provided with the information. It seems like communication kind of fell off between himself and the office. That's really important to ask for. I had another patient, I think it was last week, I don't know, time blurs, but she was told by the doctor on the report, suspects inflammatory bowel disease. And then the pathologist didn't confirm that. The pathologist didn't find that there's inflammatory bowel disease. So there was a lot of questions there. And then ordinarily with inflammatory bowel disease, you might be recommended to take medications to decrease inflammation. It could be biologics, could be steroids, it could be many different types of drugs. And that really is to try to induce remission. And we know nutrition can be so impactful for inflammatory bowel disease. You know, so many studies show that eating more plants, not less, which some might tell you, right?
Yes.
Some practitioners will recommend to patients, oh, it's irritated, don't eat fiber. Well, how did you get there in the first place? Dysbiosis likely. So we can then properly kind of try to manage some of that inflammation, right? It's an inflammatory disease. So trying to quelch some of that inflammation is going to be really important.
And not just providers, or doctors, right? Gastroenterologists, it's even dietitians. So that's in that provider umbrella. And this is where dietitians need to understand in what we call this is a low residue diet. A low fiber diet is essentially a low residue diet. Many times this is what's prescribed. And it's like, what? Like, it's insane a little bit, right? And that's okay to alter the diet. Obviously, someone in a huge, massive flare, you're not going to go, okay, eat a big kale salad with flax seeds and peas and all these beans, right? Obviously, that's not going to be the case. But the goal is to increase maybe soluble fibers, soft, broken down fibers and different foods, and still plant foods can definitely be a major factor in that diet and that plan. So to say, you know, low residue, low fiber diet and just say, okay, go on your way. Here's what you do on top of other things, you know, that's not the whole story. And a lot of times you see patients avoiding foods that are actually beneficial for them.
Remember, guys, what feels good right now for your gut is not always good long-term for your gut. So you really want to work with someone who's knowledgeable, who can help you identify what will feel good right now, sure, to kind of calm some of your symptoms and try to get you into remission. And then what's going to keep you feeling your best, not just good, not just great, your best for the rest of your life.
And this is where, you know, there's many factors, like you said, and this is where it overlaps into some IBD, IBS, as well as people who are watching and listening, just going like, I want to learn more so I can stay healthy and prevent any of this from ever happening to me, and even for your children. So, you know, obviously genetics play a role, but what we're finding out is most of the DNA in our body is microbial DNA, or a good majority. So that's crazy. I mean, let me say that again. A majority of the DNA in our body is actually microbial DNA. That is bacteria, archaea, that is fungus, right? So all these different microbes, that's crazy. So we're more microbial than human. So our genetics are kind of a mix. Yes, it's mom passed down, you know, or grandma, great grandma, and all that lineage, sure. But it's being influenced, and this is where you get into that lifestyle, epigenetics, nutrigenomics. That's a whole nother topic, right? But
it's a good one.
It's a really good one. We got to add that one for sure. Where you get into, okay, what is affecting my DNA, which is really cool. And then your microbes are a big part of your DNA. Really cool. So there's that, of course, lack of fiber. So you're not eating enough fiber. You're not eating chia and flax and kale and potatoes and all these wonderful, great fiber sources, fruits, nuts, vegetables, seeds, beans, heavy antibiotic use. Oh my gosh. I grew up in the 90s. Antibiotics were like, it's like Oprah. You get antibiotics. You get antibiotics. Everyone gets antibiotics. Yay, antibiotics.
You get antibiotics with your sticker at the doctor.
Yeah, I got a toy and I got my pink amoxicillin and gum. I'm chugging it. It tastes like bubble gum. Yay, mom. And just tons of antibiotics, right? So, you know, not breastfeeding. I was not breastfed as a child as well. So there are many factors: smoking, alcohol use. Then we get into stress and trauma. We get into environmental toxins. So there's many I guess, factors on this list, and there's subcategories within this factor. And it's not to overwhelm you, but it's to understand we've kind of built this environment over the last, several decades that have really fostered poor gut health. So now it's like working hard to get back to a place of healthy, balance, right? So a healthy homeostasis in our gut. So unfortunately, we're in this predicament. Like we've said, we've had a public health disaster for many, many years before, all the craziness going on now. And it's important to understand that. It's important to make changes, and especially changes focused on the gut. Because when you focus on the gut, you are focusing on full body health. You are focusing on a lot of root cause medicine, root cause approaches that really, really help you. So all of those risk factors are risk factors for IBS and IBD. A lot of them overlap, okay? So that is a huge, huge overlap.
And knowing them can, again, help kind of shape your choices, like James was mentioning. So maybe you're someone, we know heavy NSAID use, so non-steroidal anti-inflammatory drugs like ibuprofen, or many others that are NSAIDs, high-dose aspirin. You might be someone who says, yeah, I've taken those for a large majority of my life. I've lived with migraines or my menstrual cycle, or I've had injuries. Yeah. Maybe then you can look into other alternatives, since we know those alter the microbiome, and it increases your risk. Again, maybe you're someone who's been on a low fiber diet, but maybe you have a family history, someone in your family has Crohn's or colitis. That can hopefully help shape your choices, where again, you're feeding those microbes. So that way, again, you're producing less of those inflammatory types of microbes. They're lower in abundance. They're balanced out with those amazing firefighters, the anti-inflammatory microbes, and you're decreasing your risk, and you're decreasing prolonged suffering and perhaps misdiagnosis. So you're doing things like knowing your family medical history to assess your risk. You're eating fiber-rich foods every single day, not just some days, but every single day. And you can work with your care team to decide the amount that works best for you. Yeah. You're avoiding excessive antibiotic use when possible. And like I mentioned, non-steroidal anti-inflammatory drugs as well when possible. You're trying for vaginal deliveries and breastfeeding when possible. It's not always possible, and that's fine. You can't go back and say, Mom, please vaginally deliver me. But you can make changes in your diet. You can make changes in some of these other things you're using. And when it comes to breastfeeding, that's where you get the best HMO. I'm not talking about an insurance plan. We're talking about human milk oligosaccharides. That is the best HMO. Your insurance HMO probably isn't the best, but HMO, human milk oligosaccharides. Yes. So doing those things, again, reduces chances. You might not have control over those things that happened before in your life. I wasn't breastfed. Now, maybe you're saying, I want to reduce my environmental toxin exposure. So maybe I'm choosing healthier personal care products, makeups, sprays that I'm using to clean my home with, pest care management that's used around my house. So many layers to this. I'm drinking out of glass or stainless steel rather than plastic. So all these little changes you have control over, and these can be very impactful to your gut. Try to manage your stress with appropriate outlets to help navigate stress rather than avoiding it, because it kind of bubbles up inside of you. And stress is a natural part of life, right? It's a natural part of progression. Stress can be good. Stress is a healthy part of life. Like exercise is a little bit stressful. Sometimes challenging yourself to learn a new skill, like learning a new instrument, a new language, reading new information. That's also stressful. Sometimes even positive things like planning a party, which is good. It's celebratory, moving. It's good, but it's a little bit stressful. Right. So learning how to manage that stress so then it doesn't end up affecting your microbial balance. When we are mentally stressed, that can create more of that inflammatory microbiome and more of that inflammatory response. So that certainly can impact things. Trying more natural pain management methods, like I was saying with the NSAIDs. Trying to avoid excessive alcohol, refined foods, like James was mentioning, smoking, alcohol. Yeah, super, super important. And again, this overlaps a lot with IBS. Like a lot of these recommendations we would recommend to our IBS patients as well as our IBD patients. So this is the overlap here. Now, when it comes to, which I think we'll get more into part 2, but when it comes to some other differences, when the gastroenterologist is going in
for the colonoscopy, they are going to visually see IBD, right? They're going to see, and
sometimes, unless it's microscopic.
Unless it's microscopic, right? For the most part, but I'm saying the big difference from IBS and IBD is you can see for the most part the damage being done. And what we find, and especially Crohn's, is that you're kind of an inside-out burn patient. You're not burned on the outside, you look burned on the inside, and specifically your colon. So it's visual. Like they can diagnose it there with that colonoscopy and go, whoa, there's major damage going on. Or
and it might be just in the small intestine with Crohn's. It could be all throughout.
Right.
So Crohn's could be small and large intestine.
Correct. And so you can see this damage. You can see that there in the colonoscopy. Whereas with IBS, they're going like, okay, we're not seeing anything. What are you talking about?
Your scopes look great. Endoscopy is all clear. Colonoscopy is all clear. So it can take a little bit more finessing to diagnose those. But being very diligent, communicating with your care team, having different members on your care team who can give you that insight of, okay, we all know, we've heard physicians sometimes, and even dietitians tell patients, well, it's an autoimmune condition. It doesn't matter what you eat. But different members of your care team might kind of bring to your attention, well, you've been telling me for months that you've been having really bad period pain. You've been using a lot of ibuprofen. Maybe that's affecting things. You've been telling me you've been very stressed. We see on your labs that you might be deficient in certain key things like calcium, vitamin D, omega-3. We know these are prevalent in IBD patients especially, but IBS patients as well that can be prevalent in. You're telling me you eat a lot of inflammatory foods like fried foods, highly refined grains, highly refined sugars. You drink a lot of alcohol. What can we change in that? Maybe we're changing the amount of emulsifiers that you're being exposed to, right? Those things that bind fats or lipids to liquids. So maybe
think of salad dressings.
Yeah, salad dressings and peanut butter. So things that bind those things together. Maybe you're having a lot of emulsifiers, which can be irritating, causing inflammation. Again, maybe you're not eating enough fiber. Maybe we want to help you make more of those amazing short chain fatty acids, which can help kind of repair things. And we know those are really predominantly produced when we're fermenting fiber. So it's important for IBD. It's important for IBS. Can be tricky with both. And there's different nutrition management for both. So we have different protocols that we'll employ for our IBD patients than our IBS patients.
And I think, and that's why we kind of need a part two. I think possibly part two is going to be a little bit of that protocol preview and going into more of the diagnostic and the overlap. What's interesting though, and this is something we can get more into, and even possibly in the part two, which is we're finding that with Crohn's, especially Crohn's remission, where you think like, oh, great, I'm doing great. I'm my Crohn's is gone. I did a colonoscopy. It's looking great. Doctor's like, everything is wonderful. You're doing a great job. Maybe you made lifestyle modifications. You're on medication possibly, and you're doing things the way you should, and your Crohn's is in remission. We are finding that Crohn's remission especially is associated then with possible IBS symptoms where, again, you're now like, okay, I just had Crohn's IBD and now I have IBS because I'm still bloated, gassy, I'm uncomfortable. I may be having some diarrhea here and there, but my colonoscopy looks great. Maybe my labs are looking great my stool test isn't showing anything. What the heck is going on? So then boom, now you've had IBD and IBS. So that is a possibility as well. And so there are some studies showing that it's affecting at least 25% of patients who have been in remission with Crohn's, which is a significant amount. So that is another connection of IBS and IBD, so that it's important to understand. And it kind of reminds me of like diabetic patients where you can be a type 1 diabetic and a type 2 diabetic, right?
It can be 1.5.
1.5. So that's what we call that. And it's interesting because you're like, how the heck does that happen, right? And so that's a whole nother topic, but it reminds me of that overlap, right? Where we do categorize diseases, but there's so much overlap because everything is connected. And even diabetes is connected to all this too. If you have diabetes, you're at risk for these diseases even more. So it's all connected.
It's all connected. It all matters. They can intersect. There was a 2020 study that showed that about a third of patients with IBD reported symptoms compatible with IBS, just to kind of reiterate James's point.
Right. Yes.
So things can get missed. And I get it, guys. I would say one of the top things I hear from my patients, which makes me sad, is I've lost faith in the Western medical system. So I just don't even want to seek out care. And there can be that happy medium. It's frustrating, and I completely understand how you can become jaded when you're being told, you're normal. Your papers are normal. Your scopes are normal. So you're normal. And you're like, no, I'm having symptoms.
Right.
I don't feel well. But you're being told, nope, it's all in your head.
You're
De-stress.
fine.
It's just because you're stressed. So like we said, stress might be playing a part into it. But we recommend keep advocating for yourself until you find the right care team. My patients oftentimes come to me looking for very holistic disease management. And sure, if it's possible, let's do it. Let's try it. But it's not always possible, especially I would say with something like IBD. You really do want to be diligent, keeping up with your blood work. You don't want to have to find yourself in a huge flare or a huge crisis where maybe you've put off scopes, you've put off colonoscopies for a long time. Maybe you have Crohn's, you've put off endoscopies for a long time. You've put off blood work. Maybe you're avoiding taking medication because you never induced remission. And then you're coming and saying, what can I eat right now to reverse all of these years and years and years of symptoms? It might not always be possible. So work with your care team. Find a compassionate care team who truly listens and actually cares. If you're not just surviving, but you're thriving.
Yeah.
That is our goal for every single patient, that they're not just surviving. And it's not like, oh, you're fine on a paper, that you feel amazing. You don't just look amazing on a piece of paper as well. So that is something I would say that's key in really helping to figure out why this happened, how to prevent more of it from happening, and moving forward from there. I know we have just a few questions, and we've prioritized the questions from those who are in our group. And we always appreciate the questions that we get from our Good Gut members. So these are our patients who have seen us, and they're in one of our groups. Someone's asking, how do we know what our gut health is? There's several parts to this question, but this is part one. How do we know what our gut health is?
Yeah. How do you, that's a wonderful question.
That's
because
a topic.
That's a whole topic for sure. But to quickly, I mean, a great analogy, because I give analogies a lot, as you all know, if you've been following us for a while, is we all look like fingers, but as we move in, we see unique fingerprints, right? So that really speaks to what your gut health is. And honestly, when we see patients many, many times, patients get a realization of like, I've been constipated my whole life. So your baseline is constipation as you being normal, right? So like, what is gut health? Like gut health is I strain and I push, and there's sometimes I don't go every day. I don't have a bowel movement every day, et cetera, et cetera. The list can go on and on. So really gut health is you possibly learning a better way, right? We don't know what we don't know. And part of your gut health journey could be actually learning, oh, wow, this is actually what normal is, and creating a plan to get there, right? What is ideal gut health? Like what is optimal gut health? You are having at least one or multiple bowel movements a day. You are not pushing. You are not having extreme gas and bloating. You're not seeing mucousy, bloody stool.
You're not seeing a bunch of undigested pieces of food like greens and mushrooms and tomatoes.
And it connects so much deeper. It's really
bloated, reflux.
A well-rounded health as well. Allergies, eczema, hives. I mean, so many symptoms are then related to not just your gut microbiota, but we have a lung microbiota, we have an oral microbiota, we have a skin microbiota, and they're all in communication with one another. So it is pretty complex. And that's why we say gut is the nexus, though. That is the epicenter. That is a starting point. So that was a long answer. Again, we can go into that. I mean, very, very much in depth, but
so the part two to that question, that was it. Hopefully that answered that part of the question. What is gut health? And again, we'll do a whole live topic on that.
Yeah.
But overall, it's that you feel well. You're able to have beautiful, amazing poops that are coming out
Your poops
easily.
Feel good.
Yeah, absolutely. It's not a stressful event. So someone's saying, I had IBD Crohn's, surgery, colon removed, and I don't get any symptoms anymore. So this person had IBD, they had diagnosed inflammatory bowel disease, Crohn's.
Mhm.
It sounds like they got their colon removed. So that might then, if they only had inflammation in their colon and they did a colectomy,
Mhm.
that could have been, but there are different types of colectomy. So colectomy means removal of the colon. It could be just part of the colon. There are
Mhm.
many different parts of the colon. There's the ascending, transverse, descending. We know that, we have our sigmoid colon, we have our rectum. Like there are so many pieces involved in the colon. So they might have removed a part of it. Sometimes they'll perform total colectomies.
Right.
If you had colitis, inflammation of your colon, again, itis is inflammation, and they removed your colon and you didn't have Crohn's, so your small intestine wasn't affected and you no longer have a colon, I guess you can pretty much say you're cured. You no longer have that colon. You don't have the autoimmune attack of an organ you no longer have at all.
Right.
So it depends. Again, I'm not your care team for this person asking this question. I don't know. It really depends. I would say if you had Crohn's, and even if they did remove your whole colon, because Crohn's can affect the small intestine still, I would still keep up with your care team, your gastro. Ask them if they think that you need to have endoscopies.
Right.
This is a great question that we're getting from one of our patients or someone in our group. So someone's asking, is there a stool test to see what is going on in your gut? Such good
Wonderful
questions. I love these questions that you're all asking.
That could be a whole topic as well. What's
Yes.
interesting, and multiple studies have been showing this, is the microbiota in your stool does not always represent the microbiota all throughout your
small intestine, large intestine.
Yeah.
It's a byproduct, basically, right?
Correct.
Stool is the output. Stool is the end product of all the fermentation, all the digestion, all the absorption or malabsorption.
Right. So an analogy for that, 'cause I love analogies, would be like a health inspector just inspecting the final product, right? Let's say it's a pizza place and they're going, oh, this pizza box looks clean. Okay, the pizza looks well cooked. There's no like hair in it or whatever. And the health inspector goes, you get an A. But he didn't inspect the dining room and the kitchen and the stove and the pizza oven, and it could be a complete mess, but the pizza looks fine, right? Or typically in a stool test, though, you're maybe finding, this pizza's kind of off and maybe it has weird cheese here, it smells weird here.
It's not melting right.
But then the kitchen is beautiful and clean, and so there's so many different pieces to this, and just relying on the end product is not enough.
And just like, we get frustrated when we're discounted and told, your labs look fine, you're fine. I think sometimes I see patients who do a lot of testing, and even though they're feeling better and their symptoms are getting better, they feel that because their stool test looks off, or because some of their blood work isn't 100% optimal just yet, that they need to be super aggressive and really make a bunch of different changes, more so than they already made. So I would really go off of how you're feeling. And again, some of these tests are just objective measures, but I don't think the technology is 100% there yet with stool tests. I know some companies will give you a report, and it's interesting. I'm not going to call them out, but there's a company who does stool testing, and they're using one of the older technologies. I think they use 16 sRNA rather than the newer shotgun genomics. And they give you a report of what your stool looked like, the different microbes that were in your stool, different bacteria, whatever. And then they give a list of superfoods and avoid foods. These are like bad foods for you.
Ooh.
You guys, I've had at least a dozen patients do this test. The ones who repeat it then come back and they're like, what the heck? All my superfoods turned into do not eat foods. Again, the stool test is telling you what the end products of digestion are. If you're eating all of those foods, those superfoods that were super for you, and you already had an inflammatory microbiome, it's not just because of the foods that you ate. Again, if you're still extremely stressed, smoking, drinking, you had risk before, those foods might not even be significantly impacting it. So you want to look at the totality of your health and see, what other areas am I missing? Can I be working on any of these other areas? And maybe the stool test is a small piece of the puzzle. I don't discount them. I've ordered them before in the past, but I'm not super eager all the time to order them.
They are rarely, if ever, and I don't know. They're rarely, if ever, you diagnose off a stool test alone.
Yeah, and we don't diagnose.
Yeah, not that we diagnose,
but we will order them once in a while.
Correct, or even a doctor doing that. Yeah, but
good questions. Really, really good questions. Does it happen with ulcerative proctitis? Not sure what they're asking, but
I'm not sure what happens, but if you want to clarify, even after the live, we look at comments and things like that. So,
but it's still an inflammatory bowel disease, right? We know that it does still count as a type of inflammatory bowel disease. And proctitis, for those of you who don't know, is inflammation of the lining of the rectum. So sometimes patients don't have full-blown colitis. It might not be full-blown Crohn's where it's affecting the small intestine, even the large intestine. It might just be localized to the rectum. So treatments can be very, very similar.
Yeah.
Yeah.
Wonderful questions, you guys. That's wonderful. So like we said, I think we're going to do a part 2 on this. We've gotten some great questions. Stay tuned. Make sure if we see
the IBS with proctitis, it certainly can, because there can be very similar causes of proctitis that can induce symptoms of IBS. So there certainly can be that same overlap. It can be seen because there's inflammation. Itis is inflammation. So if any of you are diagnosed with an itis, you have inflammation.
Pancreatitis, right? So it's basically so many types for sure. So wonderful. Guys, if you want some of the studies we're referencing, feel free to message us through our website, marytout.com.
We share them automatically with those who are in our Good Gut group as well.
Yes. And so our Good Gut group, if you're curious about that, if you're a patient of ours, you can opt into our Good Gut membership. To learn more about that, you can go to marytout.com. Again, we will be live just sharing information, answering questions every other week. I think we will do a part 2 on this because there is more to talk about, but we are out of time for today. We hope you have a wonderful Friday and weekend. Thank you all for tuning in, for participating, for sharing, commenting, liking, all of that good stuff. We are so grateful to have this wonderful community, and we look forward to next time, right? All right, everybody. Remember to heal with each meal. Remember to just incorporate these lifestyle changes. It's not about perfection. It's about progress.
Feed your gut well, feed your mind well, and feed others around you just the same.
Yes. All right, everybody. Have a wonderful weekend.